Helen, over to you.
Okay, thank you very much for joining us today, and if you come late, that's fine. We're really looking forward to hearing from you and for you to take part in our session with us today. I'm absolutely delighted to be able to introduce to you Liz Herrieven. Now, I first met Liz, I don't quite know when I first met you, Liz. I think it might have been on an Access to Acute Day that we did in Hull. And I was slightly confused. I was a bit bemused at that day anyway, running around doing all sorts of different things with Alison. And I thought Liz was a consultant nurse because somebody said, oh, this is Liz, she's our consultant. And I'm thinking, oh, I didn't know there's a consultant nurse in Hull. And it was only several months later when we hooked up on Twitter and we started to talk about different things. And I thought, oh, she's not a photocopying doctor. Sorry, David Charnock. She's a doctor that can cut bits off you and make you better. And then not only is she a doctor that can cut bits off you and make you better, she is a consultant paediatrician. And that then opened all sorts of different doors for her and I to talk about different things in terms of the way that learning disability nurses don't always get to work as proactively with our colleagues in medicine, and how we, Liz and I, would really love it to be a level playing field. So here she is, hot off the aeroplane after visiting the real life Santa Claus in Finland with no frostbite, which I'm glad to see.
All fingers still attached.
All fingers still attached, but we could have sewn those on for you. That's fine. And yeah, I'm going to shut up. I'm just going to let Liz talk about herself. And then if we stay with this small group, we'll open it to a round table discussion and share. Is that okay, Liz?
Absolutely.
Right, crack on.
Thank you, Helen. I'm going to try and share my screen. Give me 2 seconds. And hopefully somebody give me a shout when you can see my slides.
It says you've started screen sharing. Oh, okay. There we go.
Hooray, hooray. Brilliant. Okay. So first off, thank you so much for asking me to come and talk to you guys today. As Helen says, I'm really passionate about the fact that we all end up doing a very similar job in different areas, and we need to work together. And I think that in particular, the medical profession is very bad at letting other people work with them. And so I take any opportunity I can to try and meet people that think the same way that I do, and try and do what we can to make access to healthcare for people with learning disabilities and those with autism more straightforward and more reliable, really. So by way of introduction, I'm going to say that I'm Liz Herrieven. I'm a consultant in paediatric emergency medicine, currently working in Hull, but soon to be working in Sheffield. I live in Hull or near Hull with these 3 reprobates, who are my daughter Amy, my son Toby, and my husband Paul. And it's this young lady who is about to kick the ball, who has really got me sucked into the world of learning disability. And here she is. This is Amy. She's now 15, so this photo is a couple of years old. She loves Ed Sheeran. She loves sleepovers. She loves packing for sleepovers and holidays. She loves baking. She loves eating. She doesn't like being told what to do. She doesn't like brushing her teeth. She doesn't like having her iPad run out of charge. And she has Down syndrome and she is autistic. And she has massively, massively opened my eyes to the issues that people with learning disability face when they're unwell. And when in my line of work, working in an emergency department, I come across people day in and day out who are either seriously unwell or seriously injured. And I've really not, in the early parts of my career, had to think about how difficult that access to healthcare might be for certain parts of our population. And she has taught me so much. since she came along. We found out that she was going to have Down syndrome when I was about 20 weeks pregnant. I'd had various scans before then. I decided not to have any screening tests. Had a previous miscarriage, and so I decided I wasn't going to do anything about the results of those screening tests. But on the initial scans, they found a few different abnormalities and wanted to keep an eye on things. So they did more and more scans, and the more scans they did, the more information they were throwing at me about different things that my child could have. And I got to about 20 weeks and they said to me, it's looking more and more like your child might have Edwards syndrome. And at this point, I thought, I just need to know what I'm dealing with. And so I went ahead and had an amniocentesis and found out 3 days later that she was going to have Down syndrome. And actually, I remember my words on the phone. I said to the woman that broke the news to me, oh, thank God, I know what to do with that. Because I thought I knew about Down syndrome and how to tackle things. And actually, I did know a bit, but not as anywhere near as much as I've needed to know since then. Her early years were mostly about being premature. She was born at 30 weeks, and about having lots and lots of illnesses, infections, sepsis, pneumonia, bronchiolitis, being in and out of hospital umpteen times. And she taught me very quickly that children with Down syndrome get far sicker than others. They do it more dramatically, they do it more quickly, and they tend to not always have the usual signs and symptoms that other children will have. She had heart surgery, she had operations on her hips and on her feet and on her eyes. And so I was regularly in and out of contact with various different health professionals. And it gave me a massive opportunity to see things from the other side. As a doctor, I was used to being in control, knowing what was going on, leading the conversation with parents and patients. And now I was completely at a loss and out of control and out of my comfort zone. And so it taught me an awful lot about what that was like. As she's gotten older, she's developed some other little issues. So when she was about 8 or 9 years old, we noticed that she wasn't really behaving the same way as her peers with Down syndrome. She didn't really seem to know how to play. She would sort things and like to put things in piles and put things in boxes and bags, but didn't really seem to know how to play. She did lots of repetitive actions, especially when she was anxious or distressed. She'd pull her hair forwards over her face. She would use different cloths and bits of material to rub away out to try and soothe herself. And she became more and more upset about various different sensations. So loud noises would make her very distressed. Having lots of people around her and lots of hustle and bustle, again, would make her very distressed. And although those are things that I had seen in my friends' children with Down syndrome, it seemed to me far more extreme in Amy. She was very sociable. She still is very sociable. She loves to chat and loves to meet new people. And if she was here, she wouldn't let me get a word in edgeways. She'd be busy asking you all sorts of questions. But I noticed around that same sort of age that her social chat was very much stuff that she had learned and was able to use sort of parrot fashion. So her way of starting a conversation with somebody is to ask lots of questions. She doesn't necessarily listen to the answers. So she'll ask you what your favorite sandwich is, what your favorite pizza is, what pajamas you've got, what you had for breakfast. And that's all her way of trying to communicate and get to know you, because she struggles to have a free-flowing conversation. And as I became aware of that, it became more and more obvious that something was different about her. And we were eventually referred for an autism assessment. It took about 2 years to get to the top of the waiting list, and then about another 18 months for the full assessment to take place. So eventually we got a diagnosis of autism to add into Amy's learning disability. That was a really difficult part of our lives because Amy's behaviour was becoming more and more challenging, I think because the world around her was really starting to distress her. And I'm going to come back to that in just a few moments. Since then, we've had puberty to deal with, which I have to say she's done remarkably well with. We are currently having issues with her sight. She's developed keratoconus and has lost the sight in one of her eyes, and the other one is deteriorating rapidly. So that's our next challenge, is to try and work out how this young lady, who is such a very strong visual learner and relies so much on visual input, is going to manage with very reduced sight. So there's always another challenge to come along, and so she's been like an ongoing CPD project her entire life, bless her. She's always had something else to challenge me with. For everything that she's been challenged with, she's given me something to challenge me, and has taught me a huge amount. I said I'd go back to that episode when Amy was diagnosed with autism, and I wanted to talk about that a little bit more, because that was the time that I really came to hear about learning disability nurses. I'm ashamed to say that I was a doctor, I'd been through med school, I worked in various different departments around the hospital. I'd initially trained as a surgeon, and then moved on to emergency medicine, and then paediatric emergency medicine. And I really didn't know much about learning disability nursing, to the point that I was a bit surprised that there was even a specialty of learning disability nursing. And at this stage, Amy was about 10 years old. So I'd had a child with a learning disability for 10 years without really knowing anything about it. Our first learning disability nurse, we were referred to because Amy's behaviour was becoming really difficult to manage. She was becoming more and more distressed at everything, and was getting bigger and more physical. And I was worried about how to safely manage her, to keep her from injuring herself, myself, my husband, and also her brother, who's 5 years younger than her. And unfortunately, that first encounter with a learning disability nurse wasn't particularly successful. She was very worried that I would want to restrain Amy, and because of that, referred us for a safeguarding referral to social services. And so my initial impression of learning disability nursing was that these people were going to be watching me, watching how I was going to interact with my daughter, who I'd already known for 10 years, and were suspecting me of harming my daughter. And actually, I did want to learn how to restrain her, but I wanted to learn how to do that safely so that she wasn't going to hurt herself or anybody else. Things progressed. Amy's behaviour deteriorated even more, and now particularly at school, she was becoming very disruptive, and was finding it difficult to manage that school environment. So was throwing things around the classroom and at other children and at the teachers, and we were re-referred back to the learning disability service. And that was where I met who I'm sure is far more representative of the learning disability nursing community. She was absolutely amazing. She went out of her way to spend time with Amy, to spend time with us as a family, to work out what it was that was upsetting and challenging Amy, and then to work through ways to try and make things easier for her. She spent a lot of time talking about emotions and how Amy might be able to recognize different emotions, and what she could do if she was getting upset by things and not managing things. And I remember one day being at home with Amy, and something had upset her. It was a change to our routine, and she was becoming distressed. But I noticed her taking some really slow, deep breaths in and out, and then counting to herself. And I thought, this girl who I had no clue could even interpret her own emotions, let alone find a way to try and settle herself, was doing something that she'd been taught by our really fabulous learning disability nurse. And she was able to try and settle herself and calm herself down when she was feeling more and more upset and distressed by the situation. And I have an awful lot to thank that nurse for. Since I found out more about learning disability nursing and the amazing skills that you guys have, I hope I haven't done too much, but I've been trying to really raise your workload by raising awareness amongst some of my colleagues about the amazing work that you guys do, and also amongst some of my friends who have children with either Down syndrome or other types of learning disability, because I think with services being so stretched, parents don't know what's out there, and unless it's a service that they're already involved with, it's very difficult sometimes to know what you're missing out on, if that makes sense. So I'd always been very keen to learn as much as I could about Down syndrome and as much as I could about learning disability and autism when Amy got her diagnosis, purely for selfish reasons, really, to help me and Amy get through life. But things changed a few years ago when the stories of these two boys hit the headlines. Jack Adcock and Christian Sorjani, the boys from Leicester, who both had Down syndrome and both very tragically died of sepsis. And there were multiple steps along their journey in their acute illness that could have been opportunities for things to be picked up quicker, or interventions to have been carried out sooner, but they weren't. And I got into a Twitter conversation with a group of other emergency medicine doctors at the time, and the conversation was around how things were missed. And it became very, very clear to me that the things that Amy had taught me about how quickly children get unwell when they have Down syndrome, how they're more likely to get sepsis, how they're more likely to get serious illness, how it's more difficult to access healthcare if you have a learning disability, about how difficult it is sometimes to be assured of a decent clinical assessment if you have a learning disability. How difficult it is to tolerate things like blood tests, cannulation, being in hospital, having an oxygen mask on, all of those things far more challenging. And I realized that I was in a really privileged position in everything that Amy had taught me, that my colleagues didn't know. There's very, very little training out there in the medical profession around learning disability. In emergency departments, we come into contact with people all the time from all walks of life with, as I said earlier, serious illness, serious injury. But we're not taught anything in our training until this year about learning disability and about how people with learning disability are at great risk of health inequalities, about how we might need to use reasonable adjustments in order to assess them and manage them properly. Back at medical school, I had one lecture on Down syndrome, and that wasn't even fully on Down syndrome. It was part of a genetics lecture, and it was mentioned then. Then later on, when I did a paediatrics attachment as a med student, we had to learn a whole series of clinical features that somebody with Down syndrome might have. So we had to learn about the single palmar crease and the funny shaped eyes, and the fact that they might be more likely to have a cardiac condition. But we learned nothing about how difficult it is to access healthcare, about how communication problems might be an issue, about how there might be some sensory processing issues, about how children with Down syndrome are more prone to infections. Nothing at all, nothing of any use to my future career. Looking at emergency medicine training, this year our curriculum has changed. So doctors that are training to be emergency medicine consultants, there is now, after a little bit of arm twisting and heavy persuasion, a section in our curriculum about people, not just children, people with learning disabilities or autism, and PMLD and complex needs, which I'm really, really pleased to see in there. But up until this point, there's been nothing at all. In paediatrics, even when you'd expect there to be a good chunk of training around learning disability and complex needs, a lot of that focuses on social needs, around things like hearing problems, sight problems, sort of more chronic conditions. It doesn't focus on the acute illness, serious illness, sepsis, the increased risk that these children may have. And there's very little in there also about how to assess children when they're acutely unwell. Same goes for general practitioners. Very, very little in their curriculum about how to assess a seriously unwell person if they have a learning disability. There's stuff in there about the annual health checks and about more chronic long-term health needs, but very little about what to do if somebody becomes acutely unwell. And I think that has got a huge impact on the fact that people with a learning disability are more likely to die of treatable conditions. So one of the things I've been trying to raise awareness about is that, yes, there are various anatomical problems and physiological problems that come with all the different syndromes and genetic causes for learning disability, and that there are many, many comorbidities that we need to consider that will make people more at risk from ill health. But it goes far beyond that. We know that people with a learning disability more likely to succumb to infection, and COVID has shown us that multiple times. And again, that's not just because of conditions like Down syndrome that have carry with it a weakened immune system. It's also because of the way that we might assess somebody, how we might set out to manage their condition. One of the things I've been trying to raise awareness about is the fact that illnesses come along in disguise in many, many people with learning disabilities. That children with Down syndrome, for example, don't always regulate their temperature very well. So when we in the emergency department are looking for a child with a high temperature, we might miss that fact in a child with Down syndrome because they might not have that high temperature. That children with Down syndrome, if they have pneumonia, for example, are more likely to present with diarrhea and vomiting than a cough or a temperature or shortness of breath. And so we need to look beyond our usual signs and symptoms and look for other things that might be going on. Children with neurological conditions and adults with neurological conditions that are part of their learning disability might not be able to get that fast heart rate. They might not be able to have a fast breathing rate. And so those signs and symptoms that we're taught are triggers, will give us a high score, high early warning score, and mean that we have to treat for sepsis, might just not be there. And so we need to think very carefully about how we assess these people. Communication and clinical assessment and examination are, we have to say, more challenging when somebody has a learning disability. But for many of my colleagues, they might stop at that and say, yeah, it's more challenging, full stop. Because they don't have the necessary skills or knowledge to be able to work out how to proceed with that assessment. So that's something else that I'm really keen to keep working on, is letting people know that yes, it is more challenging. We can acknowledge that it's more challenging, but we need to then do something about it. And if that involves using alternative forms of communication, or making sure we have a stack of communication resources, or that we have trained members of staff that can use Makaton, or if we're incredibly lucky, have access to a learning disability nurse, then it can make a massive difference to how we assess and manage these children. Diagnostic overshadowing, again, is something that I know that you'll all be very familiar with, but something that my colleagues in emergency medicine and in paediatrics might not necessarily think a huge amount about. And actually it's something that can be a problem in all areas of medicine, not just involving people with learning disability. It's always very easy as a clinician to jump on that first diagnosis that springs to mind and not look beyond anything else, not ask questions about what else might be going on. And one thing that I'm again very passionate about, I'm passionate about lots of things, you might have noticed. Another thing that I'm very passionate about is listening to families. we in the emergency department have a lot of very stressed families, a lot of very anxious families, a lot of very frustrated families, and it can become so common to have anxious and frustrated and upset and angry families in the department that you kind of end up blocking that out. But what we need to be thinking is, why are they anxious, frustrated, upset or angry? What's happened in the past to make them more worried now? Why have they even come in to see us today? Because we tend to dismiss a lot of people and say, oh, well, they shouldn't be here, there's nothing wrong with them, it's all fine. But actually, if somebody has made the effort to come to the emergency department, particularly with a child or an adult again, with learning disability, it's a big conscious decision that they've made, because it's not an easy environment for these people. Amy doesn't like the noise, she doesn't like the machinery, she doesn't like the people around her, she doesn't like hearing the alarms going off, she doesn't like seeing the flashy lights, she doesn't like having a blood pressure done or oxygen levels recorded or a temperature done, she doesn't like being poked and prodded, she certainly doesn't like needles. And so for me to decide to take her to the emergency department means that I'm really concerned something is going on. And we have to see that in other families as well. We have to ask families about soft signs. We have to take notice when they say that they're not sure exactly what is wrong, but they know that something is wrong, because they spend day in and day out with their children and their loved ones. And I think that's something that is very, very easy to forget to do when you're very busy in the emergency department or in other clinical settings, to focus on the patient, not listen to the family. But actually the family can be a huge information resource. So this was one of the first projects that I worked on a few years ago now, actually. And this was as a result of that Twitter conversation about the 2 boys in Leicester. And a lovely emergency medicine consultant called Linda Dykes put this together with me. And this is all the things that we thought, or the top 10 things that we thought might be useful for other emergency doctors to know about children with Down syndrome. And I'm very pleased that it's gone far beyond emergency departments now, and people are using it in all sorts of other settings as well, which is brilliant. And Linda's gone on to support parents with a couple of other children with a couple of other different conditions to do similar sorts of posters as well. Off the back of this, I was very privileged to be able to do blogs and podcasts and speak at various conferences. And I'm really grateful that I've been able to get a lot of this information out into mainstream social media and online learning platforms. So don't forget, the Bubbles is one of the biggest, probably the biggest paediatric online learning platform globally. And even just today, they have released a video which I'm not in, I'm very sad to say, but is it features their founder member talking through the Teach mnemonic and talking about how best to assess children with complex needs in an emergency department. And I'm so grateful that they were able to let me help them to write that script and to put it together. And it's got out there now into mainstream education for clinicians in emergency departments and paediatrics. And I'm hoping by chipping away at these things that we can start to change the experience that people with learning disability have when they come to the emergency department. I've also been very lucky to be able to talk to lots of parent groups, because I strongly believe that we all need to work together. We're all part of the same team when it comes to looking after people with a learning disability. Parents are part of that team as much as the medical staff and the nursing staff and all the allied healthcare professionals. And we all have our various roles to play, but every one of those people needs to be involved in order to get the right outcomes. So particularly over the last 18 months, I've been working alongside the Down Syndrome Medical Interest Group and have spoken to various parent groups around COVID, about recognition of serious illness in children and adults. I keep saying children just because that's my main background, but also involved with adults, and around vaccination and answering queries and concerns around vaccination, and hopefully putting lots of minds at rest about the fact that the vaccine is there to try and reduce the amount of critical illness that our loved ones with learning disability might encounter. So more local to home and in Hull, we're very, very lucky in Hull that we have a fab bunch of staff working in our adult safeguarding department, and that includes a learning disability nurse, and we have one learning disability nurse for the entire trust, and she is run off her feet. But because there is a group of people that are all wanting to get the best possible access to healthcare for patients with LD, we have been able to have regular meetings to look at that access to healthcare, both as a general thing across the trust, but also on an individual patient basis on occasion. So we've written various care pathways for people who we know are at increased risk of certain conditions and are likely to need to come to hospital as an emergency. And those care plans start out in the community with roles for family members and carers to do out in the community, follows through the GP and the community learning disability nursing team, and then into hospital, so that we can, for example, if a certain patient becomes critically unwell, we know that we'll get a pre-alert in the emergency department that this patient's coming. The senior doctor and senior nurse on duty at the time will put aside a room for them. We'll remove equipment from that room to make it less threatening and less sensory stimulation. We'll have a designated member of staff that will look after that patient, following a care pathway to know exactly how best to communicate with them, the do's and don'ts about how to manage them. We have a pathway then that will show us which ward is the best one for this person to be admitted to, and how to do that safely. And I'm really pleased that we've been able to do that on a number of different occasions with various patients. And I hope that that is something that can be mirrored in lots of other trusts as well. It takes that teamwork, but it's absolutely vital if we're going to get the right outcomes for our patients that have got more challenging needs. This is something that we've put together in our emergency department, and this was after talking to several families in the area who had unfortunately had pretty bad experiences when they'd brought their loved one in to see us. And none of this, as I'm sure you'll agree, is rocket science. It's all stuff that we should be doing for all of our patients, LD or not, but it's the stuff that is most easily forgotten when we're busy. And so this is something that is now talked about in induction for all our new nursing and medical staff. It's something that is in all the waiting areas, something that the reception team know about, so that we can all try and do our best to try and make things a little bit easier for people with LD and for their families as well. And we have lots of communication resources as well, which are in boxes throughout the department, so that if we have somebody that has a particular need, then staff can go to that box and hopefully find something that will help them through their stay in the emergency department. I've also been working with our local Down syndrome support group, and they've put together a really, really fab hospital passport. Now, whenever I talk about hospital passports on social media, with families or with healthcare professionals, families tend to say, well, nobody ever reads them, why should we bother? And health professionals say, well, they've got information in it, I already know. I know what medications they're on, I know what health problems they've got. But the real beauty of these things, as you guys will know, is that it tells you how to communicate with somebody, how to pick up on the fact they might be in pain, and how best to be able to assess them, what's going to make them upset, what's going to make them feel calm and comfortable. And that 2 minutes spent reading something like this can make a huge difference to a patient. So one of the learning disability nurses that works with our local Down syndrome support group has put this together, and has made sure that all the children that are supported by the group have got a copy, that it's regularly updated, that it's something that the hospital team know about. I've shared these with the hospital team so that hopefully people are aware of it when they come in. Another thing we've been able to do, working closely between the hospital and the charity, is putting together alerts on the electronic patient records, so that if children with Down syndrome book in, then not only does it flag up this child has Down syndrome, because that will be fairly obvious when they book in, but what that means. So the fact that having Down syndrome will mean that they might have communication problems, that they might have sensory problems, that they're more likely to develop sepsis or serious illness, they're more likely to have atypical symptoms and signs, and it encourages whoever's opened that alert to get somebody senior involved in that patient's care. And again, that's something that I'm hoping can be rolled out with other patient groups as well across the trust. So that's page 1 of the hospital passport. Page 2 has got those Down syndrome tips and some other communication tips. And then there's some symbols and Makaton signs that are also included in there. We're very lucky as well that our nursing team have all been able to do some Makaton training. And so that, I think, makes a huge difference, not just to their ability to communicate with many of our patients, but also their confidence in communication. I think you can watch as much Mr. Tumble as you like, but unless you've developed some confidence in actually being able to communicate with somebody that has communication challenges, then it doesn't really help you at all. We think nothing at all of asking for translators when somebody doesn't have English as their first language. So we need to get more used to, in healthcare, looking at other ways to communicate when people have other different types of communication challenges. Now, I've done a lot of talking, and I told you I could talk very quickly, but I'm very interested to hear any suggestions you have about how I can improve on things like this and how I can roll out this team working across other areas as well. And of course, I'll answer any questions that you have.
Thank you so much, Liz. That was absolutely amazing as always. David, you've got your hand up. I know you've got to leave, so I'll go first to you.
Yeah, I should have left by now, but when I was hearing Liz speak, I always come to these sessions and think, I've got 45 minutes, I must go to the next meeting. I end up emailing people and saying I'm going to be late, because it just gets, and I've heard you speak, talk about most of that before, Liz, and what really strikes me about it, it's not really a question, it's a statement, is that we talk about rocket science and it's not rocket science. I have this in my head all the time, and I think as learning disability nurses, we kind of chant that a lot. It's not rocket science, but it actually is, and I think we ought to be selling it as rocket science and trying to convince those people who work in ED or other areas in health, but get them to decide it's not rocket science, and then they'll apply it to everybody else, and it really truly will be right for everybody. Because I hear adult students particularly all the time, when you say to them about people without learning disability, you need to know a bit about this person's story. They're cross at you because they're in pain. They just got on the bus where the bus driver went, what's wrong with you? You can't do this, you can't sit there. They've left 2 kids with a neighbour because they've got to get somewhere to get some help. And because we don't know that information, or they don't know the information, the whole of this relationship around I want to feel better just falls apart. People leave ED and they don't seek help anymore. And there's just this, for me, it's about selling it in that way. Actually, this is really specialist, but now you've got to decide that it isn't. You've got to decide that actually this is something we could do for. So it's just that kind of statement, really.
I completely get where you're coming from, and I think that's more than enough to make me think about how else I'm going to describe it next time. You're completely right. It's been, it might be for us just an average day at work, but for somebody to have chosen to come and see us, it's a really big decision. It's not something they've just tossed a coin. They've had to plan this whole journey around their entire family, and I think we need to pay more attention to that. And it's no small reason that communication is the biggest cause of all of our complaints. We need to be listening to people. Absolutely, we do. No, you're completely right.
And I will have to go now, Liz, but thank you so much. That was
my
really
pleasure.
Great.
Thank you for listening. Thank you.
Okay, bye.
Bye.
Bye, David. Steve.
Yeah, I totally agree with what Liz said, and also especially what David said about the rocket science. I just remember some stories of, I worked with a man with profound learning disabilities, and he had a smile on his face, but once we realised he was smiling, he was actually having an epileptic seizure. So we'd have to put that down in the hospital passport if we had one back then. And also several people with severe learning disabilities and challenging behaviour who appendix was bursting. He showed the world by hitting people. So, you know, these really difficult situations, but these hospital passports and communicating with the people who actually know them would really go well and benefit the person. Yeah,
absolutely. There's always a reason behind a behavior, isn't there? I don't think there's any such thing as a purely bad behavior, and it's looking for the reason behind it, which we don't do. We dismiss it and witter about it and move on to the next person, don't we? And we can't keep doing that.
Yeah, it still happens.
Yeah. We dismiss it because the person's got a learning disability. Because one of the things I was thinking about when you were talking about the behaviour and the gentleman, Steve, with the appendix, you know, his appendix was about to rupture and this, that, and the other, and would hit people. And it's also to be my daughter's birthday tomorrow. So I remember writing a birthing plan with some student midwives, because I was the first nurse teacher in our school to get pregnant, I think, since Mary had a donkey ride. So I was every student's project sort of business. And one birth plan I remember being asked to review and see whether it would fit in, said that during labour, you may find that you feel yourself becoming verbally aggressive. Please let us know what you want. And I do remember, and I won't swear because we're being recorded, because my husband tells this tale almost every year. It says that a physician said to me, you are managing your breathing really well, Helen. Have you been practicing? And I said, yes, for 33 effing years, because I was 33 at the time. And everybody thought that was funny. I was so cross that I'd been asked such a stupid question. But everybody laughed and nobody thought, oh, it's Helen, she's going to hit somebody soon, or she's now being verbally aggressive. Whereas if I'd got a learning disability, they would think that my behaviour was totally unacceptable and so on and so forth. The other thing that really struck home for me was the fact that and I have heard you say this before, but I had chosen to compartmentalize it and not do anything about it, is that your first encounter with one of us wasn't positive. And that, I've been reflecting on that while she's been talking, because for a lot of us and a lot of people with a learning disability, our first encounter with a physician isn't always positive.
Absolutely. Yeah.
And we then dismiss that as they've diagnostically overshadowed us, and then we diagnostically overshadow the whole of the medical profession and say, oh, they're cruel, they're this, they're that, they're not going to take any notice. And we end up, you know, and I've worked with lots of families where parents or older brothers and sisters have chosen not to take the person with a learning disability to the doctors, to the hospital, whatever, because they say, well, they won't care, Helen, and they won't do anything. I mean, you know, and some of the people on this call know about all the stuff I've been doing with the British Dental Association this year, because of people who I thought were going to die, absolutely going to die, because we were missing the golden hour in terms of sepsis, we were missing sepsis markers, or because of rotten teeth or dental abscess. But we need, you know, I have made a career saying together we're better, and it'll be tattooed on my forehead when they plant me with a daisy or whatever. But yeah, together we are better. Sue, what about your experience? You know, I know I come from a rural community in Lincolnshire, but you're a far more disparate rural community than we are, aren't you? She's fiddling to get herself off. She'll get there. Kelly, what about your experience in your new team? What's it chimed with you, or is there anything you want to ask, Liz?
I don't know. I think for me, it's really refreshing to hear in terms of like Liz's perspective of what it was like prior to being a mum of a child with an additional need, and how she feels now compared to then, because I think, as you've already said, Helen, it can be quite push and pull in terms of medics and other professionals outside of our field in terms of getting a really good understanding of what it is that we actually do. And within my team, I imagine that at some point I'm going to come across that, because I will be working within in terms of intensive behaviour support, along the sides of sort of transforming care and staying outside of hospital for people with learning disabilities, specifically children, is my area. But yeah, I don't think I've got any questions. It's just really, really refreshing to hear such honesty, because I think there are quite a lot of professionals that won't admit that they'd not heard about us, and I think that is quite common, and it's so sad, because we're such, maybe I'm blowing smoke up several backsides, but we are fantastic. The work that we do as a branch is immeasurable.
I completely agree, and I think you have every right to be proud in your specialty. I think you guys do an amazing job, but completely hidden from the vast majority of the population, including all those working in healthcare. And I think that is incredibly sad. Like I say, I had no real clue that, I might have heard of a learning disability nurse, but I'd never really considered what they might do until I came face to face with one. Even having a child with additional needs for 10 years, it's never suggested to me that we needed to see an LD nurse, or that one might be able to support us with anything, and until we got to kind of a crisis stage, and I think that is so sad. I'm now proud to know many as friends, which is lovely. But yeah, absolutely, you should be proud. Blow as much smoke as you need to.
Yeah. I'd be really interested actually to network with yourself actually, Liz, because as Helen and Steve, I'm sure you already know that I've written books for learning disability nurses and children with disabilities, in terms of the promotion of learning disability nurses, and sort of getting that understanding of what we are in their children's books, so that they're easy read, they're easy to understand. So I'd be super excited to send you a copy of the first one that came out a few years ago for yourself.
I'd love to see it. Yeah, that'd be amazing. Thank you.
We've got hopefully a pull that another one's going to come out in the summer, around transforming care, and about sort of pushing the understanding about keeping people at home and in communities and that. So we're hoping, because now I'm within the NHS bubble, I'm hoping that we'll be able to push it within NHS England. So I've got some contacts and I'm pushing it there. So yeah, if you can pop your email address in the chat, and we'll and we'll sort of liaise.
That'd be fabulous.
I'll be able to get you a book sent to you.
That'd be lovely. Thank you very much.
You'll never look at the Loch Ness Monster the same again.
No, never again.
Yeah, or probably me.
Helen does feature in it. Yeah, you're in the first one, aren't you, Helen?
So Sue's had to leave us, but she says it was really interesting, and she really has enjoyed the chat. So thank you very much. Sian, is there anything that you want to say as being a newly qualified? Well, not newly qualified. You've only been qualified. You qualified yesterday. I was Sian's personal tutor. It makes me feel very old that she now works in my team, but also makes me very proud that she works in my team.
Yeah, I just wanted to say, I think, sessions like this and hearing from people that, are doctors in kind of other fields and things like that, it just kind of gives you that real sense of proudness, and that the fact that,
I'm having
we
trouble
should
hearing,
celebrate.
I'm afraid, Sian.
Oh,
I can hear you, Sian.
Yeah, I can. Yeah, same here.
sorry, it might be because I'm on my phone.
No, we can hear you, Sian. Could you not hear at all, Liz?
I couldn't, I'm afraid. I'm sorry.
Okay, well, what Sian is saying is that it makes her feel proud, what you've said, and the fact that learning disability nurses have working in partnership Is that right, Sian?
Brilliant.
Yeah, perfect.
I don't know
Brilliant.
why
I think we should all be proud. Absolutely. It's fabulous. One of the things I'm proudest of in my current job is working with the team in the trust to get those pathways sorted, because it's something that takes several of us to do, because we all have different bits that we can bring to the table, and the whole thing would fall apart if we weren't all around that table doing it. So I think absolutely we should all be proud. Brilliant.
In terms of that spreading the together we're better mantra and whatever, I think one of the things that I have learned through watching you, Liz, on social media, as well as interacting with you on social media, is the other Liz that does the that did the pink card with you. She also does mountain rescue medicine, doesn't she? I mean, that always intrigues me. When, you know, I keep expecting to see her on 999 What's Your Emergency, and then I can say, oh, I've talked to this lady on social media. She follows me on social media, sort of business. But you know, in terms of that, you know, I have said a lot this year that you cannot rock the boat unless you get in it. And not only have you rocked the boat in your own ED department, but you have rocked the boat in the medicine world, because there are medics who work in mountain rescue, really exciting, in Wales, whoever, wherever, in different aspects, surgeons, obstetricians, you name it, who now think, even if they do it because they're frightened of you to start off with, and that's not the worst position to come from. Sometimes it's the best one, because they think, I keep looking over my shoulder because Dr. Liz might suddenly turn up and bite me if I'm not doing this properly. But then the next time they'll forget to look over the shoulder and they'll do it properly because they know that's the right way to do it.
Thank you.
So in that together we're better, yeah, you have definitely rocked that medic's boat. So thank you very much.
No, thank you for that. That means a lot. Sometimes I feel like I'm chipping away at the world's biggest iceberg, but I'm going to keep chipping. So thank you for that.
We'll come along with our ice. Sorry, Steve, go on.
I'd like to jump on the back of that medic mountain rescue with their, I thought they called them. They let you fly. You seen on BBC?
Ooh.
I don't know, you talk
like a rocket pack.
Yeah, rocket pack, that's it. You can fly right up the mountain.
Oh. No, I'm not going to do that. I'll get on my unicorn and do that instead. But yeah,
cool.
But that's absolutely fabulous. So I know you've got to take Amy to an appointment, and your time's really precious, as is everybody's time is precious. So I would like to start, unless there are any questions or anything anybody wants to make, I'd start to round this up and say thank you so very much to you, Liz, for everything you've done. But also, Neil, thank you so much to you for your professionalism and the way that you have given us freely of your time and talents to make sure all the way through the plague we have been able to operate this for anybody who wants it. We've had some extraordinary experiences doing it. We've had some, every speaker has been amazing. Like we did last time, Neil, in your name, we've donated £100 worth of sweets, not just for children, but for older people as well, to the food bank. So anybody and they're all done up in fancy gift bags with a bit of pixie dust and glitter in. So they've all gone in your name, Neil. They've gone to Lincolnshire again, because that's where I am to deliver them. But I know you like to be a yellow belly in your spare time, don't you?
I do. Thank you so much. That's so kind. And it's been lovely working with you all over the last year. So thank you.
So the last thing for me to say is that, and this will be on the recording for people to hear, is that I had hoped that I would be, and right up until last night, I was hoping I would be able today to say, this is when face-to-face positive choices will be. I was going to ask Liz if she would come along. I will still ask her if she'll come along. But at the moment, the company that we're working with to bring positive choices to everybody's life this time has said, because of the changing face of COVID and whatever, they would still let me pay, but they would reduce the amount of people I could have by 50% for keeping things COVID secure. And I'm not keen to waste that sort of money. What I am intending to do is, as you know, we're going to do positive voices with Dudley Voices for Dudley Voices for, help me out, Kelly, DV Choice, yeah, in September, and it is my intention to try and book the same venue the day before, so that I can have a positive choices event and then have students supporting the event on the Friday, which is a self-advocates event, Liz, and I'm in negotiation to see whether that can become as practice hours as well for students. So Neil will work his magic, I know, thank you very much, and put this on our YouTube channel, which makes it sound really fancy and whatever. I know your son has got an amazing YouTube channel, Liz. I have seen quite a few of the things that are on there, camping for one.
Oh dear.
Which makes me laugh. And wish you all a safe and healthy Christmas and a safe and healthy New Year. And please watch social media for details of what's going to happen next in terms of what we're going to bring to you. Steve, is there anything you want to add?
Yeah, I've had a great year. Hopefully, I know about the awareness of the PC conference this year, but hopefully we can start planning earlier for 2023 and make it bigger and better than ever.
Oh, I'm going to do something in 22, even if I have to pay for every university to have conference bags and whatever, and students to be online in their own university. I will do something.
Oh,
But
well,
as of yet, I need to.
Able to help
Thank
you.
you. It's not about being helping, Steve. You're my right hand man. We'll see what we're doing.
Cool.
I'll help in any way I possibly can. If you need me, Helen, I'm there.
Oh yeah, I want you, and I want Nessie there as well, Kelly. So we'll do it. And Sian, you've got no option, pet, because I've written it into your work plan. Okay, everybody, thank you very much, and thank you so much, Liz, for your time.
Oh, thank you all so much for having me along. I've really enjoyed it.
Thank you, Liz.
Thank you.
Okay.
Take care,
Thank you
everyone.
all.
Bye
Take care,
bye.
everybody.
Speak soon. Merry
Bye.
Christmas.
Bye. Bye.